Today we are going to learn about JVP. What is JVP? How to access JVP? How to measure JVP? How to visualize JVP? And JVP waveforms. So what is JVP? Jugular venous pressure. Jugular venous pressure indirectly measures the pressure in the right atrium, so that when the right atrium pressure increases, the JVP also increases. Normally, physiologically, JVP falls with inspiration. This is because during inspiration, the intrathoracic pressure decreases so that the heart has more space to relax. So the right atrium pressure decreases. So the JVP also decreases. But there are several pathological conditions in which the JVP rises with inspiration. For example, in the case of constrictive pericarditis. The case of constrictive pericarditis, the pericardium is like thicker. It's like very thicker. So that during inspiration, when there is enough space also, the heart won't be able to relax. And the case of cardiac tamponade, there is blood in the pericardial sac. So that in this case also the heart won't be able to relax when there is more space. Same with the case of heart failure and the fluid overload. Next is how to access the JVP. JVP is accessed in the right inner jugular vein, which runs underneath the sternocleidomastoid muscle. And why we use the right internal jugular vein is because it is directly connected to the right atrium via the superior vena cava. So that we can use this one. And we should never use the external jugular vein for the JVP.
Next is how to visualize the JVP. The JVP is to be visualized. It's not like a pulse where you can put your finger on and feel it. JVP is not like that. To visualize the JVP, the patient should be in a position seen in this figure, and after you should turn the head of the patient to the left, and after turning the head you should shine a light onto the right internal jugular vein so you can see the pulsation by yourself. The main problem is that in a symptomatic patient, should be able to differentiate whether it's a carotid artery pulsation or JVP. There are like many differences between these two. One is that JVP is seen lateral to the sternocleidomastoid muscle, whereas the carotid artery pulsation is medial. But the problem is that in a grossly elevated JVP, the JVP lifts the muscle, the sternocleidomastoid muscle, so that the pulsation may not be lateral all the time. Next is that the JVP has two positive, two negative deflections, whereas the carotid artery pulsation has one positive deflection and one negative deflection. But the problem is that the pulsations are like very quick. Like for a beginner to appreciate, it's like a difficult thing. Next, the most useful method to differentiate between the JVP and carotid artery pulsation is that when you press the jugular bulb, the JVP disappears. But the carotid artery pulsation, there won't be any change in carotid artery pulsation. This is the most useful method to differentiate between these two. Next is how to measure the JVP. To measure the JVP, the first thing is that the patient should be in a 45-degree angle, the head should be turned to left, and someone should be shining a torch into the right internal jugular vein. And after, you should find the sternal angle, which must be here, the angle of Lewis, and you can see the right internal jugular vein pulsation. It must be somewhere here, and you can also see the external jugular vein pulsations. Assume that when you shine the torch, you can see the pulsations till here. Sometimes you can see it till here. So assume that the pulsation is seen till here. So you should put your scale in a way like this, straight to the angle of Lewis, the sternal angle, and you should measure this height. This is how to measure the JVP. The normal height of the JVP is less than 3 centimeter, this height, and if it's more than 3 centimeter, it is like increased JVP. JVP waveform. This is the most important part in this discussion. And these are the JVP waveforms. You have A wave here, C wave, V wave, X descent, and Y descent. As I told before, this is the right atrium, and this right atrium is connected to the inferior jugular vein through superior vena cava. That's why we are using internal jugular vein to access the JVP. And now we are going to learn how these waves are formed. The first we'll learn about A wave. So A wave happens during the process of atrial systole. So what is atrial systole? Atrial systole is when the atria is contracting. The atria is like pushing the blood down into the ventricles. So when the atria is contracting, there will be more pressure in the right atrium as well as the left atrium. So which causes an increased pressure in the superior vena cava, which causes an increased pressure in the internal jugular vein, which causes this A wave. That's how the A wave is formed. But there are like certain conditions in which you can see large A wave, which is like larger than normal one. So the conditions are like tricuspid stenosis, pulmonary artery hypertension, scleroderma, Eisenmenger syndrome, long-standing mitral stenosis, tetralogy of Fallot. So what's happening in these conditions which causes large A wave? For example, in the case of tricuspid stenosis, there is a stenosis in the tricuspid valve. So during the process of atrial systole, when the atria is trying to push the blood down through the stenosed valve, it it needs like more contracting power so that the pressure here will be more, which will be more than usual, which can cause large A wave. In the case of pulmonary artery hypertension, there is increased pressure here in the pulmonary artery, which causes an increased pressure in the right atrium and it causes large A wave. Next is scleroderma. Scleroderma is a condition in which you can see thickening everywhere. You can see thickening, fibrosis in kidney, you can see it in heart, and this causes large A wave because you can see thickening along the tricuspid valve, maybe in the mitral valve, which causes a large A wave. Next is the Eisenmenger syndrome. In this Eisenmenger syndrome, there is a left to right shunt, so that the blood is flowing from left to right. So there will be more blood here, which causes more pressure, and then it causes large A wave. And how this mitral stenosis causes large A wave, because the mitral valve is over here, and how it causes large A wave. So basically, what is happening is that the pulmonary artery is connected to the lungs, and from the lungs it is connected to the left atrium through pulmonary vein. So here what is happening is that in the case of mitral stenosis, this mitral valve is stenosed, so there will be backflow of blood into the lungs, because when blood is trying to come from the lungs into the left atrium, the blood should be pushed against this stenosed valve, so you can see a backflow of blood, which causes pulmonary edema. This pulmonary edema in turn causes pulmonary artery hypertension, which causes increased pressure here. That is how in long-standing mitral stenosis you can see large A wave. Next is tetralogy of Fallot. In this, there are like 4 congenital heart defects. You can see right ventricular hypertrophy, pulmonary stenosis, coarctation of aorta, and this is how, because basically there is pulmonary stenosis, which can causes large A wave in tetralogy of Fallot. Next is the absent A wave. Where you can see absent A wave, it's seen in a condition known as atrial fibrillation. In atrial fibrillation, the atria is like twitching, so there won't be any A wave. And where you can see Canon A wave. Canon A wave is seen atrioventricular dissociation in which both the atria and the ventricles contract together. It can be seen in complete heart block. It can be seen in ventricular tachycardia and junctional tachycardia. Next is the C wave. So what's happening after atrial systole? So what's happening after atrial systole is that during the atrial systole, the atria is like pumping the blood into the ventricles, and the pressure in the ventricle is increased during the phase of atrial systole. And when the pressure in the ventricles is more than the pressure in the atria, the mitral valve and tricuspid valve closes. This is known as the first heart sound, and it's seen in the isovolumetric contraction. So what is isovolumetric contraction? Isovolumetric contraction is like when all the valves in the heart is closed, the aorta, the pulmonary artery, mitral and tricuspid, and the heart is like contracting like a closed chamber, which is known as isovolumetric contraction. In this, the pressure in the atria will be increased so that you can see C wave. Next is after C wave, what's happening is the X descent. During the X descent, what is happening is that after the isovolumetric contraction, the aorta and the pulmonary artery opens, these two valves. So the blood will flow out of left and right ventricles. So the pressure decreases so that you can see X descent. So this is the first heart sound. After first heart sound, you have ejection click. You can see ejection click. This is during the ejection phase. Absent X descent. In which cases you can see absent X descent? It can be seen in tricuspid regurgitation. So what is tricuspid regurgitation? Tricuspid regurgitation is a condition in which the tricuspid valve does not close properly. So normally after the isovolumetric contraction, you have ejection phase, and during this ejection phase, this tricuspid valve should be closed and the mitral valve should also be closed. But in the case of tricuspid regurgitation, this valve is not closed properly. So during the ejection phase, there is a backflow of the blood. So there won't be an X descent. So the wave will be in this form. After the C wave, there won't be X descent, it will be like this. Next is the V wave. So I'll revise from the beginning. First is the A wave, which is seen in atrial systole. Then the C wave, which is seen in isovolumetric contraction. And after you have the X descent, which is seen in ejection phase. So after the ejection phase, what is happening is that during the ejection phase, the left ventricle and the right ventricle is like pushing the blood into aorta and pulmonary artery. So during this pushing phase, the pressure in the aorta and the pulmonary artery increases. So when the pressure in the aorta and pulmonary artery is more than the pressure in the ventricles, the aorta and the pulmonary artery closes, because if it doesn't close, there will be backflow of the blood because the pressure is more here and it's less here. So blood obviously flows from high pressure to low pressure. So this aorta and pulmonary artery closes, and this is known as the second heart sound, which is seen in the phase of isovolumetric relaxation. And in the case of isovolumetric relaxation also, all the valves are closed. So there will be more pressure here so that you can see the V wave. Next is the Y descent, which is this. Y descent is happening during rapid ventricular filling. So what causes absent Y descent? There is a condition known as cardiac tamponade in which there won't be Y descent. So this is basically the summary of JVP.